All right. Well, welcome everybody. It's a little bit afternoon. We've been trying to give people some time to join in case they're coming from other meetings. Welcome to the Community Behavioral Health Information Technology Coalition. My name is John Glover. I'm with Metastar, and I'm a behavioral health project specialist on this particular task. I just want to remind you, if you're able, please use your camera. We'd love to see you. And if not, we understand, but remember to unmute yourself when you want to speak, and remember to mute yourself again when you're finished. That'll help us keep any background noise from interfering. And then, as we said, if you're new to the sessions, please indicate in the chat both your name and organization, as well as how you heard about our sessions. That would be really interesting to us to hear that. So let me go over the agenda real quick for today. We're going to have some opening announcements, and then we'll do introductions. The topic presentation today is measurement-based care and clinical quality measures, and I will be doing that on behalf of Metastar. Then we'll have a little bit of discussion about that topic, and then we'll review some additional resources we've collected for you, and we'll also send those out in notes after the session today. All right, so let's get started with announcements. We wanted to let everybody know that we've been working on a 42 CFR Part 2 e-learning module, and that is now available on Metastar's website, so you may be interested in taking a look at that. For those of you working with us on an SRA, please remember that we're targeting completion of those by the end of August. I believe we can extend that longer, but we really would like to try to get those finished by the end of August. It would help us. And then Metastar Health IT Radio podcasts, there's 2 more available now that you might be interested in. Metastar's Brad Trudell is discussing information blocking in small practices. And we also have a special guest from Wisconsin Primary Healthcare Association, Parker Garman, who is going to be sharing information related to introduction to remote patient monitoring. So those are 2 you might be interested in checking out. You can hear them both at www.metastar.com/podcast or your favorite podcast platform. And then another announcement here, September 21st will be our next CBHIC session, and it is currently scheduled to be our final one. Unless we hear differently from DHS, that will be the last one of this series. And just for those of you who again are working with us, the current grant that we're working on will end on September 30th. We are hoping to maybe have that renewed or extended in some way, but currently the grant we're working under will end on September 30th. All right, so by way of trying to get some information about how to perhaps move forward, I think Lori has a poll for us about what you all would like to see.
Yeah, I do, John, and if you just one moment, I will go ahead and launch that poll. There we go. Everyone should be able to see the poll now.
We'll give you a couple minutes to check your choices there. And if you have other ideas, please do put those in chat. We'd appreciate that.
Exactly. Okay, John, I'm going to go ahead and give everyone just one more moment. If you haven't gone ahead and voted, please do so. And there you go. I'm going to end polling, and here are the results.
Okay, so it looks like we have people really do want to continue doing this. Seems like a majority of people would like to DHS perhaps to follow up with a traditional webinar style approach to health IT topics. And there's a significant portion of you would like to continue by taking it on yourself. So we will follow up with you going forward on what we learn about continuing this work and what DHS may decide to do. Thanks, Lori. All right. So that's very helpful. Appreciate y'all's input. So let me introduce you to the group process. As we just noticed in the poll there, this is not a webinar. And so it is much more of a topic-focused learning group where we encourage your participation. We encourage you to ask questions, to offer any important information, resources, things that you may have to add to the topic discussion. We do have a simple topic presentation form that will help in this process, and I actually use that for our presentation today that I'm going to be doing. If you would like to submit a topic for discussion or would like to present on a topic, please let us know. Contact your Metastar project specialist and let them know that you'd be interested. All right. And finally, please join our conversation because we're all here trying to learn from each other, and the more of us share, the more we'll learn. So next up is introductions. So let's do a quick roll call. I am going to go down my participant list as best I can. Maybe, you know what, Lori, I seem to be seeing you.
Okay. That is fine. Should I go ahead, John, and help you with that?
I'm just trying to see. I seem to only see you.
It's probably the view that you're in, John.
Yeah, I'm not being able to find that.
Yeah.
All right, I'll go down my participant list. Okay. All right. So let's start off here with, I have a phone number, 608-220-8426.
Hi, good afternoon. Can you hear me?
Yes.
Hi, this is Cindy Halstead. I'm from Journey Mental Health Center in Madison.
Oh, hey, Cindy. Glad you could join today.
Yeah, sorry, I have no internet connection right now, so I'm joining by phone.
Oh, well, I'm glad you could join. Thanks for participating. Next, I have Dan. Dan, I can't hear you. Whoops, I think I lost, well, no. All right, well, let's move on. Next up, I have Paula.
Paula Swadek from Crawford County Health and Human Services.
Great. Thanks for coming today, Paula. And then Becky.
Hi, and hi, Cindy. I didn't know you were going to be at this one. I'm also from Journey Mental Health Center.
Great.
Hey, Becky.
Hi, Cindy.
Good deal. Nice for both of you to be here. And then I've got Claire.
Hi there, good afternoon. I'm Claire Lewandowski, psychologist at Kenosha Community Health Center, and I actually just referred somebody this morning to Journey Mental Health, so you guys are, I guess, on everybody's mind.
That's
All
great.
world.
All right. Referral.
And let's see, Fern.
Hi, I'm Fern Conitz. I'm with Orion Family Services.
Great. Thanks, Fern. And Heather.
I'm Heather McClymans. I'm from Crawford County Human Services.
Okay. And then I have another Heather Carlson.
Hi, I'm Heather Carlson. I'm the Behavioral Health Manager for Ozaukee County Human Services Department.
Great. Thanks, Heather. And Jeanette.
Hi, I'm Jeanette from Oakwood Clinical Associates. I also have Amy with me today.
Okay. Hi, Amy. Thanks for joining us. All right. And let's see. And I have Lisa K.
Sorry, I'm late. Had fire.
That's all right. And who are you with, Lisa?
Brown County.
Brown County. Thank you. And Luis?
Oh, I guess I'll turn on my video. I'm Luis Diaz. I'm from Waukesha County Health and Human Services. I'm the HIM supervisor there.
Oh, nice. Thanks, Luis. Appreciate you joining us. Let's see. And Samela.
Hi, everybody. I'm Samela Jolly from Guest House of Milwaukee. I'm the Director of Clinical Services here.
Great. Thanks for coming today, Samela. And I got Taryn.
Yeah, I'm Taryn Pratt. I'm with Unified Community Services in Grant and Iowa counties.
All right. Thanks, Taryn. And then I have Thomas.
Tom Jensen from Memorial Medical Center in Ashland.
Great. Thanks for coming, Tom. Dan, did you ever get unmuted and able to participate here? Okay, I still got Dan on the participant list, but I guess he can't get talking here. So, all right. So thanks everybody for joining us. Again, if you're new, please indicate in the chat how you heard about us. Very interested in how the word is getting out to folks. So let's see. Next up is our topic presentation. And the way that works is we'll have a presentation, we'll have some clarifying questions, and then a discussion about that topic. Today's presenter is John Glover, project specialist for Metastar. And John's a licensed clinical social worker and has been doing mental health work for the past 30 years. So hopefully he'll have some things to offer in regards to how he's done this as well in his own practice. How do you like that? A little third person introduction for you folks. All right. So Lori's put up our presentation form for us, and I thought it would be best just to stick with this format. Obviously, we can open this discussion up quite a bit afterwards, but if we look at that first piece there, it says describe and summarize the issue or scenario and the benefit of finding a solution. And so under the issue, you know, what I'm thinking in terms of measurement-based care, I'm thinking about the increased need for tracking of patient progress in behavioral health so that we can better adjust patient care to fit the needs of the patient. The goal is, and these are all very related as you'll see, is to determine the proper timing for increasing the level of care when the current interventions we're using aren't being successful, or for decreasing the level of care and even discharging or terminating care when the treatment is being successful. And I know in behavioral health that is often an issue, and we all need to work towards improving that. The benefit, of course, is that we will improve identifications of needs and for increased levels of care and opportunities to discontinue care. And ultimately, this is going to help us increase access to care for other patients. If I'm not mistaken, I bet everybody is struggling with access to care. So measurement-based care is one of the ways that we can work towards that. All right, and then the second part there is describing any recent actions that have been taken to resolve the issue and barriers encountered. So, you know, when I looked at my recent actions is I've reviewed the Kennedy Forum issue brief and their supplemental file of measures that they recommend. If you haven't seen that brief, we've got it for you, a link to it, and we'll send it out in the notes following. It's a really excellent synopsis of measurement-based care. I also found support for measurement-based care, both in the American Psychiatric Association's literature as well as the American Psychological Association. And I would note that those are not new. Those have been around for several years. And so this is not really something new, even though we're all still struggling to sort of integrate it into our care on an ongoing basis, but that's also a common thing in our practices. It takes a while to integrate these things. And then I also explored the relationship of measurement-based care to clinical quality measures. And this is really interesting because they can be extremely helpful, and you find that some of the clinical quality measures actually ask for measurement-based care to be part of, fulfilling that quality measure. So it can correlate very well with behavioral health clinical quality measures. Now, in terms of barriers, one barrier is implementing standardized screening and monitoring instruments into an EHR. So this is where those of you who are in the IT field, we would really be interested in your input around, the barriers, struggles, challenges, solutions that you found to help with that. Because we know that when we implement it through the EHR, then clinicians are more easily able to work it into their workflows and track things. And there's some great stuff that can come out of that for clinicians. And then adjusting practice workflows to incorporate periodic measurements and tracking results. That's another barrier, usually clinician barrier. For myself, whenever I was doing this, I actually could use a practice alert because it sometimes gets behind you. You're like, oh, it's been a little while since I tracked this. So while a lot of clinicians sort of complain about practice alerts, I think, at least in my case, it would have been helpful to sort of get pinged that it was time for a measurement. And then finally, another barrier is required changes to practice routines. And this is sort of just beginning to integrate this approach into your care. I think a lot of people have maybe done it with depression. Some people have begun to do it with anxiety, but there are lots of other measures out there that we could be potentially doing this with. So if you could roll on up there, Lori, we got some questions. So my top 3 questions for the group. I'm curious as to what type of measurement your clinicians are currently using to track patient progress and how you're doing that in your particular organization, whether it's a standardized approach or whether it's on an individual basis. And if you know of any particular clinicians or ways that they're doing this, particular topics they're addressing. Like I said, I think depression, because it is a clinical quality measure, and the PHQ-9 is such a great tool for both screening and monitoring. That's a really common and good one to start with if you're trying to get started using measurement-based care in your practice. The second question I have is how can EHRs and health IT be used as a tool to support measurement-based care and tracking of patient outcomes? So those of you in IT, you might be able to help us out with this and sort of tell us how you can support us in these efforts. And then finally, the third one is, what challenges do you expect as you attempt to incorporate measurement-based care into your clinic? And then I put some associated issues down there in the comments, because you'll find that when you get into measurement-based care, it does involve improving patient engagement, shared decision-making, it improves treatment adherence, and it improves outcomes and the value of your services. So those are just some really important associated issues. All right, so let's start maybe with that first question. Really curious to hear from some of you who are willing to unmute and tell us a little bit about your experience currently with using measurement-based care in your practice. Anybody want to start off?
This is Cindy. I can start us off. Can you hear me okay?
Yes, Cindy, thanks.
Sure. So, I mean, I'm not, we've done some work with the National Council on related to schizophrenia care and looking at acuity and looking at a standard way for reflecting acuity, but in terms of integrating or implementing like a clinical pathway or something around that, we didn't get that far in the grant funded collaborative that we worked in, but we were we were trying to look at measures of effectiveness and acuity, and then the amount of service units that were used for different acuity levels. So that was one dip of the toe in the water. More consistently, though, what we're doing is looking at recovery markers for our community-based programs of that are in the program participation system. So employment, educate, meaningful social activities, or school, or in living situation, jail days, what else? Hospitalization days. Those are the ones that come to mind. There's like 7 of them that we're looking in our community programs to benchmark ourselves with ourselves right now. I don't know if there are any PPS. I think we've asked for if there are benchmarking data at the state, and haven't been able to find ways to benchmark ourselves with like organizations. The other thing in terms of our EHR that we're just, what's that? The last thing that we're doing is our certified EHR has electronic clinical quality measures embedded in it that we've used for testing for a stage of meaningful use. And we are actively turning those on. So some of the standard types of assessment tools that we would be using in those are like the PHQ-9, and for looking at depression screening, and also the CCSRS, which is used for suicidal screenings, and then there's like a CQM that has to do with if someone screens positive, do they have a safety plan in the same day? So those, that's not the whole value-based or measurement-based care kind of continuum, but that's where we are on the continuum of starting to use standardized performance measures for decision-making and for value-based payment and for accreditation and other purposes.
That's fantastic. You're actually deep into it and already coordinating this with clinical quality measures. That's great stuff. So it's interesting to me too, Cindy, that you've started looking at schizophrenia and acuity. Do you have a measure that you're able to use to track that?
Well, we use our diagnosis information for identification, but then we use the National Council put us in touch with an academic medical center, contracts with the government to develop standardized performance measures, and they helped us identifying data that we were already collecting in our system about suicidality, hospitalizations. I don't have it at the top of my head, but to then acuity score, to risk score our folks to see if we were providing differential care based on someone's acuity level. Were they getting a lower level of care in the organization if their acuity was less severe? And again, that whole idea of tracking movement from higher to lower acuity levels, we were very much engaged in looking at that. But yeah, it was like we took like 7 things we already collected in our system, and we used this organization's recommendation for how you create a acuity score for people with serious and persistent mental illness like schizophrenia. And then starting to look at the utilization for those consumers and their outcomes in terms of living independently, being involved in meaningful social activities, school or volunteering, jail, hospitalizations, that kind of thing.
So some social determinant of health type stuff
Yeah.
that you're using?
Yeah.
Yeah.
Yeah. And I know multiple other, like if they had a diagnosis, if they had a physical health condition, that was also something that would raise their acuity level. So if you had schizophrenia and diabetes versus just having schizophrenia alone, of course that got you scored and a higher acuity of care. It wasn't all social determinants of health. It was some physical health measures. There were about 7. They had a large laundry list of things we could pick, and we just took the low hanging. They said start with what you can do, and so things that were in our EHR, we chose those. And diagnosis is the easy one, although you have to. We're a behavioral health center, and we had a grant funded program where we were doing integrated physical health care as well. So then we would have more diagnoses that had to do with physical health. Now we're just trying to get, in terms of like medication reconciliation, trying to get not only the medications that the psychiatrist prescribed, but also that the physical health doctor prescribed. So we are trying to be more mindful of integrating the physical health and the mental health, and the acuity assessment we did also recognize that you've got to look at the whole person and bring all that to play.
Good work. A lot to do. I'm hopeful that we get some other measures that kind of help us track this, but I think, in our particular area, we can maybe identify some things that would be useful. So great stuff, Cindy. Thanks a lot. Other people, things that you're doing in your organization around measurement-based care, or that your clinicians are doing?
Hi, John.
Jeanette?
How are you?
All right.
So we are utilizing Valent right now, and Valent does offer quite a large variety of different measurements tools. The providers are using the assessments and the treatment plans to determine which of the measurements they want to utilize with the patients. And there is a list of about 19 or 20 that they use pretty consistently with patients. The PHQ-9, scared for child and parent, SPIN, SDS, COWS, CSSRS, the DAS 21 and 22. 21 and 42, I'm sorry. The HDCLC, IPDS, EPDS, GDS-15, the GAT-7, MDQ, MEQ, PCLC, PCLS, and PDSS are the ones that I think the most commonly used. So.
Wow, that's a lot of choice. And when I was doing some of my research for this, I noticed that Valent does have quite a lot of support around measurement-based care. You find that your clinicians are using those then? I mean, it's not obviously something that you're set up for. Gonna pull Amy in, right?
I probably ought to be the one talking about this.
Okay, Amy.
Because the measurements cover a wider range of presenting problems or illnesses, as clinicians, based on assessment we then maybe I'll pick the Y box because I have a patient with OCD. And then typically our standard is to, what triggers us to get a second measurement is every treatment plan review.
Treatment plans, yeah. Okay.
Yeah, every time we do a review, we redo the measurement so that it can get incorporated into the review process. And so all clinicians are really individualizing the use of measurements to the patients.
Gotcha. That makes a lot of sense. It definitely needs to be patient-centered. So as an organization, though, it sounds like you're doing your best to support measurement-based care, and that the Valent IT or EMR has been very helpful in terms of that. Do they provide you some sort of flags for that?
No,
No?
they don't. That's on our own.
Okay, that's on your own. And you've chosen to use a treatment plan as a way of monitoring that then, right?
Yeah. Some providers do it more often, particularly if there's a higher level of severity. But 3 months worth of treatment and then reviewing if that score changes. Yeah, that seems pretty standard. And we have it implemented with probably around 60–65% of our patients. We have measurements involved.
Oh, that's great. That's great. I'm curious, Amy, are you finding that that the patients sort of appreciate it, and are the providers beginning to be able to identify with the patient that things are getting better and we can probably end care? Are you noticing that?
Yeah, we've been using it since, oh my gosh, for 7 years. So and gradually we've done it more and more and more. The patients love it, and they particularly love it when you show them the graph that's integrated. So we can actually show them the graph on the computer screen, and they like that a lot.
Yeah, that's interesting, right? I mean, I think we're all motivated to try to make things look better, right? So,
and it's nice because they also see the patterns, like the depression getting worse every winter and getting better every spring.
Yeah. So they begin to learn a little bit more about their own pattern of symptomology, right?
Yep.
And I see in the chat, Fern, you have a question for Jeanette?
Sounds like clinicians have a menu of assessments to choose from rather than a set.
Yes. Yes.
Yeah. Here at Orion, we've been historically, most of our work has been in-home individual and family therapy with kids and families. And the last number of years, we've had a program evaluation effort, and we've had a set of assessments that we use routinely with every family. And as we move more into outpatient service provision, and also as we try to find assessments that clinicians are comfortable using, the clients are comfortable responding to, and they provide a reliable program evaluation, we're considering moving towards having basically what you're talking about, having a menu of assessments that the clinician chooses from. And as the agency is growing and our client base is growing, it would provide, a higher number of completed assessments to give us some data to look at. So it's interesting to me that you're successfully doing that, and kind of provide support to the idea for us to just move towards that as well.
Yeah, I think there's a great advantage to having some set assessments. We're still trying to get that going in the area of substance use disorder, having some set assessments for the entire population, because that would be beneficial. We just haven't gotten there yet. But it is much more individualized when we can pick the assessments based on the patient's presenting problems and symptoms.
Yeah. And would all the assessments in your list, I made a note of a few of them that you named, but would all of them have been validated and reliably used for program evaluation as well as clinical use?
They've all been validated. You can find them all. You can find research on all of them, the history on all of them with simple Google searches. So some of them we choose not to use. They don't seem as valuable. So I haven't specifically used it for program evaluation. Ours is, I mean, unless, I guess I am using it, but I think of it more in the sense of patient progress. So
yeah, that's kind of how we've defined program evaluation in a sense, is looking at, actually we're moving towards looking at impacts for the client rather than just outcomes. So yeah, that's kind of how we are what we do, is what we're doing working for our clients.
Yeah.
Yeah.
So Fern, it sounds like the menu idea is something you think might work for you in a different area than what you've been doing. It sounds like the, what did you call it? The set works in the one area that you've been applying it in.
Yeah. When we've been doing family therapy, in-home family therapy largely. So the routine assessments would be substance use screening for the caregivers, a parental stress survey, which is done at beginning and end, life events checklist and PTSD screen for caregivers and kids above 6 years old. And then the child abuse potential inventory was routinely done with parents that we're working with. And we've also been using the CAFAS, which has been around for a long time, and that's a pre and post screening as well. Some of the initial, the life events checklist and the PTSD screen and the substance abuse screen are done at opening to give us a picture of the client base that we're working with, and also to assist in treatment decision making. And the CAFAS is more looking at child functioning and caregiver functioning, I think.
Yeah.
We had tried some other assessment tools that ended up being just hated by clinicians, and yeah, if you hate it, you're not going to use it to the best, effectively. So
it's one of the challenges, right? We need something that's brief enough that clinicians can access and use it with a patient and move through it, and yet still effective in giving us good information, right?
So can I just put one thought with that as well? With the measures in Valence, the providers can assign those to the patients. They can do those when they're at home. They log into their portal, they complete the assigned measures that are there. That's not something that has to be done. They can do it in the waiting room. They can do it in the office. Yeah, they do it in the office. They can do it wherever they want. If the provider chooses, they might do it in session, but it's not necessarily always done that way.
Right. So are they assigned based on the diagnosis?
Correct.
Or symptoms to rule in or out, help rule in or out a diagnosis too.
Okay. Interesting.
It's great. And that kind of brings us into the use of the portal and IT stuff. So maybe it would be good to shift that direction. And it sounds, Jeanette, like your EMR, Valence, and I got to say, Fern, if you want to check out Valence work website, they do have a lot of information about measurement-based care, and how they're doing it. But the patient portal is a great way to provide that, as Jeanette and Amy are talking about. And there's some caveats in terms you got to be careful what kind of, assessments you put out there and some of the questions, and you might need a disclaimer or, something, a warning about, for instance, the 9th question on the PHQ-9. People have come up with different ways of having to, deal with that question. But it is a way to provide some of those assessments to patients so that when they come in, the provider has them all ready to go there. So in terms of the health IT portion, can some of you talk a little bit about, it sounds like Jeanette's already talked about how Valent has helped them quite a bit. And you can tell she's said they've been at it for about 7 years. And so that kind of says, this is really not new, but it is something that can be very valuable and helpful to us in behavioral health. And I think as a field, we're all moving towards it. So from a health IT standpoint, things that people have done in their organizations to help move measurement-based care forward?
John, I can kind of comment from that standpoint, not because we've really been able to incorporate it into our EHR, but because of the struggles that we've had to incorporate it into our EHR. It hasn't been as useful as I think it could be. So as I'm listening to everyone share their experiences from an Ozaukee County standpoint, we offer outpatients and outpatient counseling services, crisis, community support program, and comprehensive community services. So in our EHR is one that really was not intended to be a medical, like health record. It's more of a case management system that we also use for the other programs within our county. So we really had to, hold on one second. We've really had to make it work for us. And so from a measurement, like a measurement standpoint, from when individuals come into our programs, we do like a substance abuse screener. We've used the DAS. Our crisis and our outpatient uses the Columbia Suicide Severity Rating Scale and such. Where I feel like the challenge comes into play is being able to, like when I heard, I think it was Jeanette talk about the graphs that people love to see, like, oh my goodness, that would be so beautiful, because you can take the data that we've gathered over time for that individual to help them see, the progress that they've made, and hopefully, pull nuggets out of that as to, what might be triggers, what might be helpful in their recovery, and so on and so forth. And then from a management standpoint, I wish that there was an ability to take that data and really look from a program standpoint. And then also listening to Journey Mental Health speak, we report through our program participation system, the PPS as well. And so there's all these data points that are there, but I don't feel like we're really able to capture what that means necessarily beyond an individual level. So I think it definitely informs our individual practice with an individual, but even that can be a stretch sometimes because they have to interpret that data for them, because we don't have a system that does that for us. We basically do it on a piece of paper and we scan it into our system.
Yeah. Well, that's a real advertisement for getting a EMR that would help you manage some of that, right? Because
I just need to find I need to find a treasure chest of money.
Yeah, right. Well, we've tried to make that point that behavioral health did get kind of left out of some of that initial money, right? But yeah, I've seen the positive impact of graphs, in terms of working with patients, and it's really nice to see. They do get very, very engaged in that, very interested in it. The literature says that patients learn a lot about their symptoms and their process of treatment from, engaging in both the measurements, those screening tools, the monitoring, and looking at the results. It's excellent for patient engagement. So yeah, we'll have to find you some money, Heather. Other folks in regards to ways that you've used the health IT?
Hey, John, this is Chris. Jeanette had a question for Heather in the chat about what system they're using.
Oh, yeah.
So it's called Harmony, Web Harmony. I can pretty much guarantee you've never heard of it, and most people haven't as well. It's a system that that Ozaukee County had brought on, I believe, back in 2008. And like I mentioned, it's really more of a case management kind of based system that, because we utilize it for the other programs within our human services department, it really does not offer the, you know, the components that you all share with regards to more specific health reporting and, you know, the measurement based stuff. So.
Great.
Thank you, Heather.
So I'm wondering, some of you are, you know, more in the IT end of things. Are you finding that your EHR is able to support this, or are you having to do a lot of work to create tools in it to do measurement-based care for clinicians? I mean, what are you finding with the sort of behavioral health EHRs that are available to you?
This is Cindy. Some of the assessments were standard in our EHR, and so we adopted them, like the ASAM and the PQ, the PHQ-9 and the CSRS. And then others that we used to use in our old uncertified EHR, like the trauma inventory and others that people have mentioned on this call. We haven't, gotten permission if it's an instrument that requires permission or fees to use, and some are not compatible with our EHR. So while there's the clinical desire to use more instruments, and sometimes I believe they're done on paper, like the kids trauma inventory, that one of our outcome measures is that you know, over 90% of consumers will have that screening done. So we might do it on paper. It's not embedded in our EHR yet, and where that work falls is lower priority to other higher priorities right now. I know we're going to get to barriers, and one that's on my mind related to all this is we seem to still get bombarded by payers for a large number of unstandardized measures, of non-standard measures, and we're working really hard to advocate for using standard measures, but there's still a lot in contracting that goes on for the use of non-standard measures that take programming time and put some of these other IT requests, you know, lower on the priority list. It's always scarce resources. You know, we're always trying to choose from amongst many competing things. And related to the portals, our EHR takes a lot of setup to do the portals and connect our forms and that kind of thing. And I know when we were trying to decide about having consumers, for instance, sign the release form that they sign to do virtual telehealth appointments, we ended up going with DocuSign because it was highly reliable, and we didn't have confidence in whatever that mechanism would be in our EHR that we could roll out as fast and as cheap. And there were a lot of other things competing to be done. So just a couple thoughts.
Yeah.
On what you.
Yeah. Thanks. Yeah, it's something I think our team has noticed is that, you know, a lot of folks in the behavioral health field are working with EHRs that have a huge variety of capability, and some of them are strong in some areas and weak in other areas. And so it's definitely an issue. And I think sometimes it depends on the IT support that an organization has to you know, contribute to the development of things that it might be needed as well. All right. I see that we're running low on time here. Thanks for you all's participation. I really appreciate it. We have a couple of things we want to do here before we end today, get you guys out on time. Chris, maybe would you run us through the resources that we created, and there'll be additional ones in the notes, but we have a few resources here.
Sure, as soon as we can, there they come, I think.
There you go.
All right.
There they are.
Yeah, first couple of resources there, just quickly, is John had mentioned these in his early on in his presentation there from the Kennedy Forum briefs. Those would be good to look at. Also, next link there from the APA. I guess kind of 2017 was the first year of the merit-based incentive payment system, which probably doesn't affect any of you. I would be surprised. It's really, you're not required to report unless you're seeing a pretty high volume Medicare, but interesting to look at what the APA says and commented on them. And also one resource that isn't on here, we're going to forward, it's from a company called HealthMonics. It's a current up-to-date list of behavioral health CQMs that they recommend for reporting in the MIP system. And the reason we're doing this is, Medicaid, in Medicare, it's tied to reimbursement. I don't know that Medicaid will ever go there, but it's a recurring theme. We keep hearing about quality measures and some tie to Medicaid from DHS. So it might help to look at those and be familiar with those measures. And that's why they're in there. Next resource is from pubmed.gov. Talks about promoting measurement-based care and quality measure development, and the APA Mental and Behavioral Health Registry Initiative. So some interesting stuff there you might want to take a look at. And the final one from JAMA Psychiatry, implementing measurement-based care and behavioral health, a review, another kind of good review of that, what's happening there. So look for those when we send out the post meeting notes here.
Yeah, great. Thanks, Chris. And the team made note that a couple of those are abstracts, and you may need to, have a subscription to JAMA or something to read the entire thing. But basically, it's a sort of an encouragement to incorporate it. So let's see. We have one more poll we'd like to get in today. Laura, do you have that available?
Yes, I do, John. Let me just pull that up real quick.
Just like to get a sense from everybody what topic you think would be useful for our final session.
Yes. Here we go. Here we are. You should see the question right now, and please choose the top 2 topics of interest from the list below, and this would be for our September meeting. And if you do have other ideas or things that you'd like to talk about, please be sure to select other and put them in the chat.
Yeah, we want to make sure that we're addressing the topics that are most important to you. So we try to keep tapping the participants to find out what would be most useful.
I'll give it just another moment or two so we can get everyone's in. All right. With that, I'm going to go ahead and end polling and share the results with everyone. Here we are.
Hybrid telehealth, huh? Yeah. So that is a big topic. Hybrid telehealth, who to offer telehealth to and when. It's a great topic. I would really appreciate it if someone would be willing to fill out our little brief presentation form and tell us what you're doing just to kick off discussion next time. And that'll help sort of everybody else sort of talk about what they're doing, what kind of success they're finding, what kind of challenges they're finding. So hybrid telehealth looks like will be the the next topic. And if you're willing to kind of give us a brief idea of what you're doing, we really appreciate it. So the next session, again, is September 21st. I appreciate everybody's participation today. Thanks so much for all you're doing to help our patients and to continue doing this work. I know you've been under a lot of stress lately. Can't tell you how much we appreciate all that you've done to try to make sure people get the care they need. And thanks for joining us today. You guys have a great rest of your day, and hopefully we'll see you in September.